Okie dokie, let's take a look. Let's make sure everything's good to go here. All right. Make sure we're on the same place. I think we're doing good. I think everything is okay. Okay, let's take a look. I think we're in the correct chat here. Awesome. Chat is up and running, which is good. Everything looks good. So let's just make sure we share this on the appropriate platform, which is obviously Twitter. After we do that, we'll get going. Okay. Almost there. Almost that time. Okay. Okay, here we go. Almost there. All right, I think we are currently shared, which means that if that's correct and everything is good, then it's time to rock. And also, it is time to roll. Good afternoon, good evening, good morning, whoever you are, wherever you are. I am Dr. Patrick Lockwood. In this case, I'm just Patrick. And this is UnShrink Me. And this is a weekly podcast, for those of you who don't know, that is focused on everything related to the concept of mental health, whether it's clinical psychology, psychiatry, therapy, coaching, rehab, treatment, etc., etc. This podcast is dedicated to doing two things and literally only two things. So first and foremost, we want to talk about whatever is trendy and make sure we have an accurate view of whatever is currently trendy. That's the first thing we're trying to do. But the second thing we're trying to do is provide appropriate critical skepticism about the types of services that are available, about what is helpful and what is not helpful. And so this is a kind of like a scientific skepticism podcast dedicated to everything related to mental health. And so I will not be critical of individuals and people. I will be critical of ideas, because ideas need to die, people need to live. And generally speaking, many of the ideas in mental health as an industry are outdated, oversimplified, and in many cases not helpful. And many practitioners, unfortunately, go to schools where they learn outdated ideas. And so I want this podcast to be user-friendly and friendly to all consumers of mental health services in all cultures. So this podcast is for the public, and if anyone from the profession is here, like Darren is here from the profession. Good to see you, Darren. Glad you're here. Good evening. I know it's late where you are. Please find yourself welcome to be here. Please chat. Please share, like, subscribe, all those fun things. And this is a podcast that is fueled by, but not necessarily sponsored by, Celsius. I love this stuff. It's awesome. And this is never mental health advice, so please don't sue me, etc., etc. This is not information specifically targeted towards you and your individual mental health needs, your family or loved ones' mental health needs. This is just my musings about the industry, the systems, the ideas, etc., generally. Hoorah, Phil. Glad to have you here in the chat as well. All right, so we have a lot to talk about today. Last week, I promised I would talk about what exactly is quality clinical training, because a number of people on Twitter have been asking about it. And the other thing that showed up last week was, what exactly are the bounds of, what is mental health? What do we know? What don't we know? Things like that. So we're going to start with some of those things, but we're going to try to spend as much time as possible today talking about quality training, what we can know, what we do not know, and what it means to be ethical despite all of those things. And Jonathan's here as well. Look at that. We got 3 of our regulars here. That's awesome. Very happy to have you all here. I hope to hear from literally all 3 of you as this podcast progresses, as we dive into things. So without further delay, let's start with a softball, and we'll dig into the more challenging stuff in just a little bit. So let's start with a softball. So softball number 1, I'm going to retweet this right now. So I hope you follow me on Twitter. My handle is at Alobha Patrick, at ALOBHA PATRICK. And this is Lori Gottlieb. She is a therapy influencer, I think East Coaster, if I'm not mistaken. So let me just retweet this, and then we'll dig into it real quick. Right quick, as they say. So here's what she said. Excuse me. So Lori said this on January 7th of this year, so just recently, a couple weeks ago. She said, before you give advice, try this. Empathy first, advice later. When someone shares a problem, your instinct might be to fix it, but what they often need first is to feel heard. So the reason I call this a softball, and it's not like super deep or anything, is because generally, the idea that empathy should be the first thing you do when someone is struggling is a pretty common sense one, in the sense that if you listen to most therapists online, on Instagram, on Twitter, on YouTube, people like myself, etc., you would hear a lot of people say something like, yeah, most people don't really need solutions. Most people need just supportive listening, right? That's a very common sense, intuitive thing that a lot of clinicians have been saying for decades now. So she specifically said, empathy first, advice later. When someone shares a problem, your instinct might be to fix it, but what they often need first is to feel heard. So I want to pick apart a couple of things, because these are easy to pick apart, and I think many people will walk right by them without taking them seriously. But because of what I do for a living, and because of my training and my experience supervising interns, I take this very seriously. So, empathy first, advice later. And then she said, what people often need is to feel heard. Okay. So there are decades of ideas and dozens of layers to the concept of feeling heard, right? And this is something that's very, very deceptively simple that I want to make sure we expand and unpack just a little bit, because it actually relates to the second topic today, which is clinical training. What is ethical clinical training? So thing number one here. To feel heard, the typical English connotation there, what she means, I believe, and I haven't specifically asked her, so if I'm incorrect, Lori, and you hear this, please tell me I'm wrong, or, help me understand. So when someone feels heard, it's some combination of feeling safe, feeling relaxed, feeling some emotional, motivational state where it's like you're tuned in and you're alert and oriented and not anxious, not manic, but you're just kind of calm and open and receptive and all these things. So that's the physiological, emotional piece of it. But feeling heard also means that when the person across from you is recognizing what you're saying, they can, for instance, summarize as a clinical skill. The person is summarizing what you said to them accurately, or they might expand on what you said. They might elaborate, or they might paraphrase. They might even rephrase it in words that are similar to whatever you just said, because that's their way of understanding what you just said. So feeling heard is not just an emotional experience of feeling safe or feeling calm or feeling on the same page or vibes are good or some shit like that. It's also a literal, explicit, I think I heard you say this. Is that correct? Right? That's what good therapists do, is they say, I think I heard you say this. Is that correct? So they're checking their understanding of what they believe they heard you say, right? So ethical therapists will try to check in with you and see if everything makes sense. Darren's commenting, this reminds me of a poem someone once gave me. The first line is something like, when I ask you to listen and you start giving me advice, you haven't done what I asked. Active listening. Yeah, exactly. And by the way, Darren, I know you're not from this time zone, so thank you very much on a completely different continent for staying up late and coming to chat and share. Really do genuinely appreciate it because you could just be sleeping. So thank you for being here. It's definitely true, as what Darren's sharing here, that when people want you to listen, it's the most important thing in the world to engage in what he called active listening, to paraphrase, to summarize, to use these clinical skills openly and honestly and curiously, right? So it's one part the vibe between the two of you, it's one part using the clinical skills, but it's also, to be perfectly clear, in a clinical setting specifically, it's also there's an intent to how you engage in active listening. So you're listening with the intent to be curious. You're listening with the intent to understand. You're not listening with the intent to respond, if that makes sense. So your listening behavior has nothing to do with your desire to respond. It has everything to do with your desire to understand and expand upon or make sense of things. So that's a major difference between like being a friend who just listens versus being a professional who just listens, for instance. Because when your friends listen to you, in theory, they're listening because they want to support you and help you and blah, 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 blah. But when a clinician listens to you, you being understood is sometimes more helpful than even advice, for instance. But then I want to go back to what she said specifically, which is that what they often need first, is the phrase, is to feel heard. So the reason I think Lori is saying what they often need first is because for most people, they are more receptive to advice, etc., when they feel heard, when their defenses are lowered, when their vulnerability is acknowledged, for instance. Because without acknowledging the vulnerability, people might be defensive, for instance. So it's really important to be clear about who you're sitting across from as a professional. And if you are a patient or a loved one of a patient, feeling understood is more than just vibes. It's also the use of appropriate clinical skills, but it's also the correct attitude. And the attitude is, I want to understand. Advice is not about understanding. Now, clinicians can also share advice. That's not weird as well. That being said, it's usually second, third, or fourth tier down the list because advice is not usually helpful for most people who have serious mental health issues. Sometimes it is, but it's usually not. Usually what's most helpful is feeling understood and encouraged specifically. So what I would add to Lori's little post is, you can definitely start with empathy, but I think empathy is a very flawed concept if you see Paul Bloom's work. What I hope for people is that they feel empowered. Now, for some people, feeling empowered, feeling encouraged is very hard to do because when you have serious depression, major depression, PTSD, etc., it's very hard to feel empowered because you have all these complicated thought processes that keep you feeling less than, for instance. So it's never just as simple as be empathetic, because also your empathy is about you. It's how you are built, right? So when I'm trying to be empathetic, I'm trying to put myself in the other person's shoes. But the problem is I'm putting myself, how I'm built, my personality, my culture, my experience, my cognitive apparatus in their experience. And I can never know how the person's built, how they feel, for instance. So it's always fantasy. So empathy is tricky. I think rational compassion could be good. I think active listening is good. I think summarizing and paraphrasing is good. I think encouragement is good. All these things are very useful skills used in an individualized way. So again, Lori is prone to putting out these little ditties, these little pieces of like advice. She's herself giving advice, interestingly enough, in her post. Her advice is be empathetic first before you give advice, which is fascinating. So anyways, just a little kind of like introductory topic. Now let's dig into something slightly spicier. Okay, so Nick Tabor, who is very critical of the profession, in different ways than I am, actually. Put out this post last week, and I want to follow up on it. So I'm going to retweet what he said from last week, and we will see if this is helpful, not helpful, or something in between. Okay. So last week, Nick and I were in a heated discussion. Not really heated, but we were in a discussion about how well you can train people and if you can train people to actually accurately understand the inner lives of other people. So here's what he literally said on January 10th last week. He said this: I guess this is the core question. Can people actually be trained to accurately interpret the nature of people's inner lives? Question mark. Excuse me. I'm going to say no, he said. That's my opinion. They can be taught something that is probably, by and large, in part ideology and move forward on that basis. But the mind or soul isn't like biochemistry or material science or accounting. Treating it as such is inherently dehumanizing and often damaging, in my opinion. I mean, I make interpretations about people's inner world all the time, and on an individual level, we probably need to do that to navigate life effectively. That's empathy. That's my addition. But it's not an objective science, and I don't think we should have specially anointed experts who hold official truth here. So, as always, Nick has these long posts responding to things that I've said and other people have said. So this is in response to me, which is, I was saying, yes, we can train clinicians to have an accurate interpretation of the inner worlds of other people. So, without further delay, I'd like to respond to many of the things that he said and then lay out a model of clinical training that might make it easier to do things like become more and more accurate about the inner worlds of people. That's what clinicians do. That's what ethical clinicians do. So let me speak to a couple of quotes from Nick's tweet here before I dig into anything else. And please, for those of you who are watching and listening, let's chime in, please. So question number one, can people actually be trained to accurately interpret the nature of people's inner lives? Yes and yes, both actually and accurately. Yes, I'm going to say yes. He says, I'm going to say no. I say, I'm going to say yes, and here's why. But I'll get to that in just a second. So this next sentence of his is a really important one. They can be taught something that is probably in large part ideology and move forward on that basis. I'll speak to that as well. So 2 points. Can we be accurate about interpreting the lives of other people? And number one, how much of that is ideology? Number two. So 2 points that I want to come back to. The mind or the soul isn't like biochemistry or material science or accounting. Completely agree, Nick. I couldn't agree more. I talk about this all the time, and it's extremely, 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 extremely important. And he says treating it as such, like material science or chemistry, is inherently dehumanizing and often damaging. I also agree with those 2 points. So I'm going to get to what I think is true here. The mind is not like biochemistry. Even though we use chemistry to examine facets of psychology, biochemistry, neurochemistry, that is not a complete picture of how the mind works. The mind is an ecosystem. So for those of you who are watching, listening, you've never heard me say this before, I want you to hear this loud and clear. Your brain is just one piece of this thing we call the mind. The mind is a construction. The mind, the operating frontal-facing system we can consciously see, is an ecosystem. And that ecosystem has multiple living dynamic creatures in it, including your brain, but also the brains of other people, but also sunlight, but also air, but also all these environmental stimuli that are affecting the mind. So your mind is a dynamic thing constantly bombarded and interacting with the world outside of it. It is an ecosystem. The mind is not your brain. Your brain is the organ that facilitates the creation of the mind, but your brain does not equate to the mind, if that makes sense. So it's like saying your heart gives you life, when in reality it's like you need all of it to give you life. For instance, the heart's extremely important because without that you die. Just like without the brain you die. You need both technically, right? So I want to get to what Jonathan just said, because what Jonathan just said is probably going to dovetail very nicely with what I'm about to say. So Jonathan just said, I saw that exchange and thought about chiming in. What Nick is not taking into account is that we innately interpret the inner worlds of friends and family members via mirroring. Exactly. So this is something I was about to say, Jonathan. So what Jonathan is saying, what Nick he's refuting something Nick is saying. So he said, a quote from Nick's post said, they can be taught something that is probably in large part ideology and move forward on that basis, right? So the thing about that is that in one sense, if we're going to be a little philosophical about it, everything is ideology, right? So you have politics in your brain, you have economics in your brain, you have spirituality and religion in your brain. Our brain is bombarded with dozens of ideologies, and some of them we agree with because of our culture and how we're built and all these things, and some of them we don't. So in the most facile, superficial view of what Nick is saying, he's correct that clinicians are taught an ideology, which is true. On the other hand, what is not true in what Nick is saying is that when clinicians are taught to observe symptoms, to observe patterns of behavior, patterns of verbal expressions, patterns of feelings, patterns of reactions, and then look at the bigger context of the person's life and understand constructs like personality or intelligence or memory or whatever it is. When we put all of these things together, it's much more complicated than just some ideology about what is considered healthy, for instance. So, Nick, you're incorrect that all that clinicians learn is something that could be boiled down to ideology. That's not true. It's a very superficial way of looking at what clinical training actually is, unfortunately. Because if it were just that, this would be super simple and we'd be done. Clinical training would take a year. It wouldn't take years and years and years and years and years. So Jonathan also said, there's a finite, this is Jonathan saying, there's a very finite number of emotional states that humans experience. And we tend to display a high degree of universality regarding these states under particular stimuli. So there's some truth to that, Jonathan, but also I'd encourage you to check out a lady named Lisa Feldman Barrett about How Emotions Are Made was her popular book from 2016, I think. She's a neuroscientist. So we don't have universal emotions in her view. We have universal reactions to some degree, in the sense that we have like these reflexes we've inherited over time, such as, fight, flight, freeze, fawn, and submit. But the ways that our brain elaborates on those and we create emotions, in her view, is that there's some subjectivity and contextuality to it. That's not just happy, sad, angry, afraid, all that stuff. So I think it's more complicated than that. But I believe you're correct in the sense that human beings have a finite number of ways we can react. We do not have an endless number of ways we can react. We can react with different types of moods, different types of energy, but we don't have countless energy or countless numbers of energy or countless types of moods, right? Because our language is inherently limited. So if you believe Lisa Feldman Barrett's work, it's very simply that our emotions are constrained by the type of language we have. So if we only have 20 words that describe something akin to fear or anxiety, then you have 20 different types of anxiety or fear you can experience, basically. So there is an upper limit, which means that to the extent that, mental health and the mind, etc., are language games, it's an inherently limited system because we have limited language, right? So then now that's pretty high level, so I don't want to walk by it quickly, but I just want to say very clearly to everyone, my view has evolved a lot since I was in grad school. I started out with their 6 universal emotions and everyone's the same, which is bullshit. Your inner world is constrained by how you can describe it, basically. So if you have a very large vocab, you have a very complicated inner world, comparatively speaking. If you have a very tiny vocab, you have a very small inner world, comparatively speaking. And so, to Nick's point, to some degree, ideology plays a role because ideology is involved in grammar and syntax and things like that. That being said, it's very important to be clear that clinicians are not trained to just let some set of specific ideas run their life, right? Like, I can tell everyone as a professor in graduate psychology teaching future master's level clinicians and doctoral level clinicians that it's very complicated to get your degree and then do the work correctly, because it's not just here are these 5 truths about what it means to be healthy and then go take these 5 truths into therapy and explore the mind and then make sure everyone agrees to these 5 truths. Like, that's not what happens. right? So for instance, it'd be easy to simplify mental health training and say, being symptom-free is mental health. But none of us were trained that way. I was not trained that way. I doubt anyone in the chat here was trained that way. So it's not as simple. There are no really simple paradigms that any of us are taught, if that makes sense. We are taught very complicated paradigms. So we're taught about, the cognitive triad, right? We're taught about, antecedent behavior consequence. We're taught acceptance and commitment therapy, which has the hexaflex and 6 processes and 6 pathological avoidance processes. So we're taught all these things. We're taught dozens and dozens and dozens of things that may or may not be applicable in a given situation, right? So what we're taught is contextual, Nick, first and foremost. So if things are contextual, then they're not dogmatic or ideological, because the opposite of ideology is context, essentially. But the second thing that's also true here that I think everyone should be listening to, if you're in therapy, if you have a loved one who's in therapy or treatment or rehab or whatever, it's that the idea that clinicians can't be taught to have an accurate appraisal of someone's inner world. And for that, I fundamentally disagree. Because it's true, if you go back to my earlier comment about empathy, it's 100% true that everything that we call empathy is just projection. So if I'm empathizing with someone, really that's a fantasy. I'm constructing a fantasy of what I think is happening inside the someone based upon the vibes, based upon how I feel. But the thing is, how I feel is completely constrained by how I'm built, my personality, my intelligence, my culture, my vocabulary, my life experiences. So every time I'm empathizing, I'm basically making up a fantasy about how I would feel, which is mostly informed by the data about me, not about the other person. So I don't know almost anything about the other person, so I'm thinking about what I would feel like. Now, there's this facade of rationality in therapy, which is if I'm smart enough and I'm paying good enough attention, then I can take in all the objective data, what people are telling me and how they're acting towards me. And I can make up a story about that. And then I can infuse that story with empathy. I can infuse it with my projection, my fantasy about what's happening. So in theory, what's happening is if a clinician is empathizing with a patient, they're doing 3 things simultaneously. First and foremost, they're hopefully trying to pay attention in a curious way to the patient's words, behavior, and reaction patterns. The second thing they're doing is they're paying attention to the bigger context of the patient, their life story, their culture, their personality, all those things. And then the third thing the therapist is doing with the patient is they're now projecting. They're empathizing. They're adding what they believe, the therapist's motivational states, their feelings, their vibes, all that stuff, based upon their lived experience as the therapist, as the person, with their individualness and also their training, right? So those 3 things are happening at all times when a therapist is empathizing. And if you're paying attention, I just described like 70 layers of complicated things that are happening at any given time when I say the phrase, I'm empathizing with the patient. Nope. You're looking at patterns of behavior and feelings and words from the patient. You're adding all their context and backdrop and story. That's a couple dozen layers. So layer 1 has like 12 layers to it. Layer 2, their story, their context has a dozen layers to it, a couple dozen layers. And then the you layer, the therapist layer, your feelings, your thoughts, your vibes, your history, your beliefs, your bias, your culture, all that stuff. You're projecting, you're fantasizing. All of that is empathizing. So I'm admitting that, Nick, that therapists are not doing some magically objective thing when they empathize and try to assess what's happening in the inner world of somebody else. So I hope everyone heard that, because we are not magic. We are not magically looking inside of a person. What good clinicians do is they create a hypothesis while acknowledging their biases and their limitations. Okay? So let's segue this just a little bit because there's a lot to say here. But when he says, can therapists be taught to accurately and reliably interpret the inner lives of other people? Yes, I say. Okay? So let me explain what good clinical training is, just so everyone's clear. So I'm going to start with a high level view of a good model, and then I'll speak to some specifics in each of the layers. So people getting their master's degree, people getting their doctorate degree, people getting whatever degree, it's very, very important to understand what are all the layers of clinical training. Drew, who's listening here, says, love the layers here. Clinical training looks assailable to smart folks outside of the field, especially with the rise of therapy speak. Absolutely. And it is assailable. It should be assailed, in my opinion, for sure. Thank you for being here, Drew. So now I'm not going to give away anything secret or proprietary because all the stuff I'm going to talk about is publicly available on my university's website. So everything I'm about to say, just so everyone's clear, is literally 100% publicly available on my university's website. Nothing I am saying is secret, proprietary, or whatever it is. So feel free to sue me if you want or whatever, dear university. So good clinical training, and I believe that the university that I work for and the colleagues that I have in my department actually do this. So I'm speaking from an insanely biased place of my lived experience working in my particular university for the last 8 years. So I have 8 years of data in my head about the types of graduates we turn out, how ethical they are, how reasonable they are, and how well they do the things that I'm going to describe. So I get that my university is just a convenience sample because my university is not all universities. So you can come at me with whatever criticism you want. However, what I will say is I don't believe my university is all that special in this regard. What makes us special is the fact that all of us actually agree to do the right thing and try to be ethical. That is what makes us unique. And that's why I love working there, because I have colleagues who have different beliefs, religions, spiritualities, cultures, politics, all that shit. But we all agree on one thing importantly, which is let's talk about what we believe is true. Let's talk about what we believe is useful, and let's talk about what is ethical. And if we can combine what is true, what is useful, and what is ethical into one turducken and teach that to the students, then everything is grand. And we all believe in that. None of us are like, screw ethics, and none of us are like, screw what's true, or none of us are like, screw what's useful. All of us believe that true, useful, and ethical have to be in the same sentence in order for us to utter it in our program. So that's the culture that I come from, that I'm a part of, that I get to help create as well. So I'm very grateful that I get to do what I do part-time. So here's the deal. Good clinical training involves at least 3 layers, okay? So good clinical training involves education, unsurprisingly, and that's education in theories of human behavior, theories of the brain, theories of family systems, theories of culture, all these things, right? Also, theories of therapy and these kinds of things. So that's the education piece, and I'll expand on some of those. The second part of good clinical training is supervised professional experience. Okay? So supervised professional experience, or SPE, can involve being in a practicum placement where you don't have a license, you're not even license eligible, but you're doing a specific kind of training and a specific kind of therapy under strict supervision by a clinician that's licensed and seasoned, right? Jonathan says, Theraproducin? Yes, Theraproducin. Yes, that's a Theraproducin. Yes. We need t-shirts that say Theraproducin. So supervised professional experience can include pre-licensed experience and post-degree experience as well. So we'll dig into the specifics of that. So the first thing is education. The second layer is supervised professional experience. The third layer to good clinical training involves specifically, most importantly, in my very extremely biased opinion, involves self-care, right? And so that is not going to sound scientific or professional, but I will explain it in detail. Okay? Because most grad school programs teach the first two things: education, supervised professional experience. But that third thing, that's an entirely different thing. But my program teaches it and encourages it. So, first and foremost, education. So most master's level programs and doctorate level programs have some things in common, but also some important differences. So when I teach master's level students, we talk theories of counseling, theories of family therapy, theories of systems, theories of, psychosocial functioning. We look at the impact of adolescence, school lives, spiritual lives, family lives. We look at all the systems. So there's like multidimensional family therapy we teach people, right? So there's all these different theories that look at the entire person's external experience and how it affects them in the MFT world in particular. We teach them group skills, group therapy skills. We teach them individual therapy skills. We teach them case formulation. So something you were supposed to learn in your graduate psychology education is this thing called case formulation. My colleagues on Twitter, like Dr. Ed Perrin and many others, also talk about case formulation because it's extremely important. And so for those of you who don't know what that means, case formulation is where the therapist, of whatever degree background, is supposed to come up with a model of why they think you're struggling. So if you are the patient and you walk in the door and you say, I'm having a lot of anxiety and I can't sleep. Okay, so you listed two things, which is anxiety and insomnia. Okay, so those are labels, anxiety and insomnia. Those are like big picture concepts. Those two words, anxiety and insomnia, could mean dozens of things. And so part of what you do when you create a case formulation is you gather lots and lots of information about the history of these symptoms, right? But once you've gathered information about the so-called presenting problems, then you're supposed to expand your scope of knowledge and data and gather information about their childhood, their early gestational development if you have that data, their biological development, their social emotional learning throughout early life, their personality style, their relationship history, their sexual history, their medical history, how much activity they have in their life, what they've done for work, if they've done any work. You're supposed to look at all the different facets of the person's life on top of their presenting problem, when it started, when it got worse, when it got better, what changes it, what doesn't change it, all these things. So I just listed probably 50 things in a very summary way. And so those 50 things, putting all of them together to create a hypothesis about why you have anxiety and insomnia is not a simple thing. And it's not a one and done thing. It's not like this brilliant computer genius therapist brain comes up with a case formulation and just spits it out and shoves it in your direction, and you, the patient, agree with it or disagree with it, and we move on. No, a case formulation is a working hypothesis that gets refined over time in session after session after session as we come to know each other more. Because part of what goes into our case formulation is how the patient reacts to us. And when I get to the second layer of this, which is supervised professional experience, I'll explain more about why that matters and how it matters. But in an educational setting, like in grad school, you get vignettes and you do all these things, and you create case formulations based upon those vignettes. But then it should evolve when you get new information. So part of what happens in pretty much all good graduate psychology training, and I believe I'm part of that, maybe biased, I don't know, is that we don't just give you a static vignette and then you move on and life is good. The vignette evolves. There's a round two. There's a part two. There's new information. Because in real therapy, what happens is patient tells you a story in the first session during your intake, and then the second or third session later, you get new information. And that might contradict prior information. It might clarify prior information, or it might add to prior information. And knowing what to do when you get information that contradicts, clarifies, or adds to prior information is in and of itself a skill. So just what I described so far in the last 5 minutes is at least a year's worth of training. At least. Now, it happens across different types of classes like diagnosis-based class and testing-based classes and assessment classes and diagnostic interviewing classes and all these things. And so most grad programs have, I'd say, 3 to 4 classes specifically dedicated to diagnostic interviewing, basic attending skills, which is a class I teach, and all these kinds of things where you're learning how to pay attention, what to pay attention to, and importantly, when I teach the class, how to make sure whatever's happening inside of you is not muddying the waters. Because when I teach basic attending skills, one of the things that I preach about, and it's literally me preaching, is when you have a reaction to something a patient's saying and it pushes you in a direction, that's most likely bias, culture, countertransference. It's one of those things. And that might push you away from what the patient needs to talk about. So I'm extremely clear in an educational setting that when you're a clinician and you have a reaction to something and that reaction is forcing you to do something, that might be bad because it might be pushing you away from the patient and what they need and where they're at. So good education also involves reminders of the subjectivity and the fallibility of being a person. I'm going to say that again. Quality graduate psychology education involves constant reminders that you are a regular person who is both fallible and biased and capable of failing. And the reason that's important is because those things that I just said will always find their way into how you listen and why you listen and what you make sense of when you listen to a patient. Jonathan says, theory drives practice. Smart. The framework I'm using guides me in what to ask, listen for, and do in response to the conceptualization. I should always be able to answer, ... He's going to continue. So I'll get back to his point. So, as I'm saying, quality education doesn't just teach you theory. And as Jonathan said, theory could drive practice. I don't think theory drives practice for most of the people I teach. And Jonathan said, I should always be able to answer how my actions relate to the framework I'm operating out of. Exactly. So there's a dialectic there. So I'm going to use little Hegelian, Hegel, whatever here. There's a dialectic in therapy. There's one between you and the patient, and there's one between you and yourself. And so the one between you and yourself is, I have this theory, I have this hypothesis, I have these ideas that guide my behavior, but how are they informing my behavior? And is there actually a truth in the middle between what I believe is true and what I want to be true? For instance, because therapists want things to be true just as much as patients do. So that's a bias you have to guard against in your clinical training and supervision, which we'll get to in just a second. So anyways, quality graduate education includes not just learning about theories of human emotion and human behavior, like, Lisa Feldman Barrett talks about in her neuroscience research, or theories of motivation, like in motivational interviewing's research, or existential psychology. It also includes theories of therapy, right? Family therapy, systems therapy, multidimensional family therapy, solution-focused therapy, all these different types of therapies, emotionally focused therapy from Greenberg and colleagues. Individual types of therapy like cognitive behavioral therapy, acceptance and commitment therapy, cognitive therapy, rational emotive therapy, psychodynamic therapies. All of these different types of theories and therapies are just frameworks for understanding human behavior and emotions. And learning these is important. But that's not all that graduate psychology education is. Not only do you learn these theories and therapies, but you also learn analytical thinking, right? This is something that's not talked about on websites of universities. And I don't mean this like in a disparaging way. I mean this in a literal sense. It's like learning how to think critically about information that's presented to you is a genuinely large part of graduate psychology training. And I say this because I do this for a living. So I'm telling you what I do as a professor, right? So when I'm teaching like a diagnostic class where I'm teaching people about the neurocognitive disorders or the psychotic disorders, I'm not just reading the criteria from the DSM-5 TR. I'm talking about the criteria We're talking about real case examples. We're talking about vignettes. We're talking about the research on these concepts. What exactly is a hallucination, for instance? How does the brain actually interpret the 5 sensory stimuli that we experience at all times? We're talking about all these things, but we're also talking about things like, on what are you basing this assumption that you're actually experiencing a hallucination, right? Because what looks like a hallucination might not be a hallucination at all. It might be a delusion, for instance. It might just be a loud and large internal voice, which is not the same thing as a hallucination. Like a loud conscience is not a hallucination in most cases. It can be, but it rarely is. So learning to think analytically, the concept of, let's call it, differential diagnosis is a big part of what I do as a professor. And the reason that it's a big part of what I do is because I want to teach you to rule things in and rule things out. And I want you to rule in and rule out dozens of things before you decide on a diagnosis. And in my world, at the university that I teach, a diagnosis is a hypothesis. A diagnosis is not a final label. It's a hypothesis, right? Because when you're trying to operate empirically, you're trying to see if what you believe is true or not. So, dear Nick Tabor, there are many, many people in graduate psychology who think like me. Many, many, many of the people that I have talked to across the country think exactly like me as professors, where they don't have some diagnoses from on high that we're teaching our students to understand and diagnose people with. Many people in graduate psychology on the education slice of these 3 things are very interested in critical thinking, analytical reasoning, and specifically differential diagnosis. We want to know, is it this or that, or is it nothing? Or is it ordinary human suffering? Or is it contextual? Something Nick Tabor talks about all the time on Twitter is how much of people's mental illness is just screwed up environments. And my response is, it's often a big part of why people are sick. And so when I teach differential diagnosis, I teach my students to think, what diagnoses could this be? What real life problems could these things reflect? Is it a medical syndrome? Is it drugs? I have a huge bias because I worked in Rehabistan for most of my career. And so I genuinely believe that many people's, emotional distress experiences also involve shitty diet, shitty relationship with caffeine, shitty relationship with sleep, shitty relationship with water, shitty relationship with the gym, all these things. Now, does that mean that your major depressive disorder would magically disappear if you just worked out more, took steroids, and had some Celsius with me? Probably not. You probably would be equally miserable but jacked. That being said, there's a percentage of the population that will believe they're depressed clinically, when in reality they're not. They have a bad case of life sucks disorder. And I talk about this with my grad students on the education side of things. Ordinary human suffering is not a diagnosis. Ordinary human suffering in extraordinary circumstances is not a diagnosis. And so understanding this kind of analytical critical thinking is something that good graduate schools do. And I know for a fact that the graduate programs I teach in teach like this and think like this. The colleagues that I have, I trust implicitly to be skeptical, to not care about the diagnosis as much as we care about the hypothesis of what we think is happening with the person's distress and suffering. All of my colleagues are very interested in creating a working hypothesis that we genuinely believe is the set of mechanisms and motivations for the suffering of the person we're sitting across from. So diagnosis is just a tiny piece, a soupçon of what we care about in graduate psychology. It's important, but it's not the most important thing. The most important thing is countertransference management, critical thinking skills, differential diagnosis, cultural conceptualization, systemic conceptualization, biomedical referrals, and all this wrapped into one. Drew says it's called adjustment disorder. Absolutely. Adjustment disorder is a real thing, and many people are adjusting to terrible circumstances. And so it's one of those catch-all diagnoses for your life sucks right now and you're having a hard time managing it, for sure. Excuse me. But is adjustment disorder Major depressive disorder? No. I mean, you might be really badly struggling like people with major depressive disorder do, but it's not the same qualitative experience. Jonathan Cogburn, one of my good friends here in the chat, says, lift heavy circle for make body and head happy. Ugh, ugh. And I agree, 100%. I'm a gym guy. I get it. However, good clinical training doesn't include just lift heavy circle, even though I believe lift heavy circle is part of like layer 3 here. Okay. So again, just to summarize, quality clinical training includes differential diagnosis, includes basic attending skills, includes countertransference management, diagnostic interviewing, theories of human suffering, theories of human motivation, theories of how the brain works and doesn't work. By the way, for any of you who are interested, we know extremely little about how the brain actually works when it comes to diagnosable mental illness. We have some idea for hallucinations. We have some idea for like OCD, for instance. But for most other conditions in the DSM, we have very vague systems that we kind of understand. We kind of understand addiction. We kind of understand PTSD, but not really. So just to be clear, we only know so much. And so biological theories are not even top 5 most important in graduate psychology education. They're there and they matter. Everyone gets a psychopharmacology class, etc., and a biopsych class, but that doesn't mean that those are the most fundamental things that we think about. We think about patterns of behavior, patterns of systemic interaction, and how people have agency or don't have agency. Also personality styles and all these things. We talk about all these things. Theories of behavior change, theories of systems, all these things. So graduate education is just an insane amount of critical thinking exercises over and over again for 2 to 5 years, depending upon what kind of program you go to. So if you go to a master's program, it's 2 years of critical thinking training about diagnostic concepts and theories and what you know and what your bias is, what your culture is, and how that influences which things you think are true, which is about as contextual as it gets, Nick Tabor. But then layer 2 is supervised professional experience, and I'll try to get through this somewhat briefly. So depending upon what kind of program you go to, so if you go to the average master's program, LPC, MFT kind of program, you will have 1 year, maybe, of supervised clinical training and what we call practicum or a traineeship before you get your degree. So before you get your degree, while you're still in grad school, typically year 2 of your master's program to be a therapist, if you're a master's level therapist, you'll be in 1 year of supervised clinical training. So you might do 15 to 20 hours a week of individual, family, and couples therapy, and you will have minimum 1 hour a week of individual supervision and minimum typically 1 hour a week of group supervision. And so in those supervision experiences, not only do you create specific concrete training goals like get better at paraphrasing, get better at active listening, get better at managing your bias, all these things, but also you have this typically seasoned therapist who is helping you look at yourself, who is helping you look at your bias, your countertransference, your culture, your differences that make you react the way you do to the patient, right? So that first year of practicum or traineeship is before you even graduate, and you're still learning the theories and getting them in your brain. Then you have another year after that, at least, if not 2 usually. So you typically have 3 years of supervised clinical training before you get licensed, right? So you have 1 year while you're in grad school before you graduate, and then the 2 years immediately following graduation. You have about 3,000 hours of supervised clinical experience you have to have before you get licensed in most states. So that's 3 years. That's, hundreds of hours of supervision where you're trying to actually see how you are making educated guesses, aka hypotheses, about what's happening with the patient, with an expert who has already been doing this for a while, who's aware of their, hopefully, countertransference, bias, culture, all these things. So it's not like when people are training to be therapists, they're like ChatGPT, where they just get some information put into their brain and they just spit out a hypothesis with no context or no awareness of how they're built. Right? ChatGPT doesn't have metacognition about how it's been trained on certain data. It just spits out information because that's what you want it to do. Therapists are not ChatGPT. Therapists are specifically trained, at least in the graduate program I work in. Therapists are specifically trained to look at why we believe this is true. We are taught to challenge. I teach my grad students and my supervisees to challenge, to second guess why they believe what is true is true. They are not taught to uncritically think, well, you just have major depressive disorder and it's that simple. I've never seen that in graduate psychology. Even the programs that I think are terrible don't do that. So, genuinely speaking, that supervised professional experience, minimum 3,000 hours, hundreds of hours of supervision. Sometimes it's watching tapes, so at my university, for that practicum year, that year before you graduate, when you're doing supervised training, you have to videotape yourself and show it to your supervisor. It is extremely informative and very uncomfortable for most trainees because everyone hates looking in the mirror, number one. But number two, you'll have a different accounting of it in your head versus what you see. So if a supervisee comes to me and says, the session was like this, but then we go watch the tape, it all of a sudden changes the way they think about it because, oh, by the way, I also stuttered 5 times because I couldn't handle my anxiety or whatever it was, or I was afraid to ask this question or whatever it was. And then we start to see where the rubber meets the road. We start to see, what is it about you, the therapist, the intern supervisee, who was unable to ask that question and be curious? Why were you afraid? Was it something in you, something in them, so on and so forth? Now, that kind of complexity and humanity and nuance is not something that's scientific, Nick. You cannot objectively, scientifically, and to your point, Nick, you said you don't want to dehumanize people by calling them chemicals. Fair enough, neither do I. So I take what I do very seriously as a clinical supervisor. I do not believe there are just chemicals that we are influencing as people, as professionals. We are complicated, Yeah, Darren says in the chat here, what do you believe and why do you believe it? Right? That's an important training question. If you're a clinical supervisor, or if you yourself are a grad student right now, and you don't have a supervisor asking you, what do you believe and why do you believe it, then you need a better supervisor. Because the truth of the matter is, whatever we think is true as clinicians is not true. It's an educated guess. It's a hypothesis. And so when you think of therapy like hypothesis testing, everybody gets treated with respect. No one is dehumanized. It's the most humanizing thing in the world to say, I have this educated guess based upon my experience, what I know, what I don't know, what I've heard you say. What do you think about this hypothesis? Does it seem correct to you? And if it is correct to you, what do you think we can try to do about it? For instance. So that's supervised professional experience. So if you're a master's level student, you have 3,000 hours, typically over about 3 years. If you're a doctoral level student, you typically have 2 to 3 years of pre-degree training. And then you have typically 1 to 2 years, maybe 2 years of post-degree training. So you have 5 to 6 years of supervised professional training before you even graduate, which means you have hundreds and hundreds of hours of supervision. Hundreds of hours of people coming back at you saying, how do you know that? Why do you believe that's true? What is it about you? How does it make you feel? Why did you say that? So I don't worry as much about the dehumanization of people because of a lack of supervised professional training. Now, I think a lot of supervisors suck. Some grad programs suck, and they don't teach you critical thinking as much. They just focus on you kind of churning out papers and hypotheses and stuff like that and being done. My program is not like that. We want you to actually be good at what you do because we care about ethics. A big part of our program is ethics. Ethics is part of every class that we teach. And that's how it should be. The third thing, which I don't have a lot of time to expand upon, but I'll explain why it's part of good clinical training. So, if it's true, if my assertion is true, that ethical therapists are aware of their bullshit as therapists. So ethical therapists are aware of their childhood stuff, their issues around sex, their issues around religion, their issues around gender, their issues around their health, their issues around money, their issues around all these things that humans struggle with, right? Because all humans struggle with these things. Relationships, friends, personality differences, politics, blah, 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 blah. Good clinical training always involves you taking better care of yourself. Because a clinician who has their shit together to some significant degree, where they actually do things like take care of their body and don't treat it like shit, and get some sleep and drink some water, and they have some relationship with order outside of themselves, and they have friends, and they have some relationship with family that supports them, they're not a giant fucking mess. Those people are more likely to be aware of the fact that they have some internal motivations that drive them to treat the patient a certain type of way. Because the more you take care of yourself, the more you realize that you're an unhinged mess. And most people who come into graduate psychology are unhinged messes. They have their own trauma, shames, whatever it is. And that's what drove them there in the first place. So getting a handle on that is part of good clinical training. So those are the 3 layers of good clinical training. Quality education that involves theory, ethics, analytical thinking, testing, diagnosis, basic attending skills, all sorts of things. Hundreds and hundreds of hours of trying to understand the complexity of the mind and the brain and human relationships and patterns and culture. In addition to supervised professional experience for thousands of hours with hundreds of hours of supervision, on top of getting a handle on your shit. Ethical, quality clinical training, graduate psychology training involves you, the faculty, encouraging the students to get a handle on their shit. Maybe that means encouraging them to go to therapy sometimes, getting more sleep, eating more water, but every student that I talk to at my university is encouraged in my classes, across all classes, to take better and better care of themselves so that they can do their job better, be more psychologically stable and aware and ethical and curious and not full of their own shit, their own bias, their countertransference, or cultural issues. So that's a very simple, brief overview of a quality clinical training model. And there's dozens more things to say, but we're out of time for today. So I hope this has made sense to everyone, because clinical training is not magical, but it's extremely complicated and it's grueling, because to be a really good clinician means to understand your shit so that you can see how it gets in the way of being aware and open and available for the patient. Because that's what happens all the time. That's countertransference, bias, culture, shame, all these things. So I hope this makes sense. I hope Nick Tabor gets a chance to watch this, because it's extremely important to understand how complicated training actually is and how graduate psychology is complicated. It's not simple. It's not just here are the diagnoses, here's some theories, and you're done. And do it this way or else. We teach you critical thinking, hypothesis testing, respect, openness, curiosity, and humility. That's what we teach you at my university. And that's why I'm proud to work there, because I have great colleagues who do that every day. So thank you all for coming out and chatting. We can talk about this more. I have so many other posts I wanted to talk about, but this is just the big one for today. Please tell me if this was helpful. Tell me if I missed anything. Tell me if there's something I have wrong. Tell me if you disagree. I'd love to know. And if you thought this was helpful, please share this with your loved ones. If you have someone who needs therapy, needs help, etc., let them know. I'm here. I can refer you out to people as needed. I'm here to support people on their journey to find whatever help they need. Definitely not me. So please like, share, and subscribe. Please come back next Saturday. This is a weekly podcast. This is UnShrink Me. This is the podcast where we do 2 things and 2 things only, which is to explore trendy things in the mental health world, psychiatry, psychology, etc., etc., etc. Also, I want to be critical of what is true and not true in the profession, what's helpful and what's not helpful. So this is a podcast for the consumers. And this is not specific therapy advice, so don't sue me. I'm not here to help you specifically. And I also want everyone to know that I am optimistic about the profession, because I know that I am not the only one in the field who's teaching students to be critical and aware of themselves and think of therapy as hypothesis testing and not some I'm anointed thing that Nick Tabor talks about. So thank you all for being here. Thank you so much. Your chat comments are awesome and fun and provoking, and we always go interesting directions because of what you say, so please come back next week. And as always, I'd like to end with a joke, and so without further delay, here we go. So I once had this patient, and this was a first for me because normally when I work with adults, I work with, kind of known things diagnostically, relationship issues or depression or PTSD. This person came into therapy because he was both blind and afraid of the dark, which I'd never experienced in my life before. This was brand new to me. So basically what had happened was I sat down with this guy for the first session. Apparently he was in a really, really bad car accident where he smacked the back of his head into the seat and the airbag and all this stuff, and he basically went blind. And he was having a hard time adjusting, and of course he was having a hard time adjusting. He was just in a horrific car accident that made him blind. And simultaneously, I guess, because of the trauma of the car accident and going blind, it also sparked a phobia of darkness. And so all day he was basically in some limbo of being terrified, of like exhausted, and it's dark and afraid and alone and lost. So it's kind of like a phobia of darkness, but also PTSD at the same time. And there really isn't any literature on this particular problem. So I just kind of leaned on general clinical skills because he was saying stuff to me like, I don't think this is ever going to be okay ever again. I don't even think therapy will work. And so I tried to explain one of the models that I think is generally helpful in these situations called ACT, Acceptance and Commitment Therapy, which is all about cognitive flexibility and acceptance and all these things. And so we basically took a very light, supportive approach, right? None of that talking about your childhood shit, just like, what is it like today? How are you handling it today? What is in your control, not in your control? What can you accept, not accept, etc. And over the course of a few months of, doing some ACT with this guy, he became a little more accepting of his circumstance. And personally, I can't imagine accepting that circumstance because, traumatic car accident, tragic, going blind, all these things sounds like impossible, right? But people overcome impossible things all the time. So essentially this like phobic anxiety response disappeared. And near the end of our work together, he came and he said, you know what, doc, I didn't really think therapy would help, but over the last couple of weeks, I've started to feel a little bit better. Or at least, this insane anxiety reaction I have, this like panic thing is gone. I feel better. But I still am really, really resentful about the asshole that hit me and how I'm blind. And I said, you know what? That makes sense. I think being resentful makes a lot of sense. I generally don't encourage it, as I've said before, but, that makes a lot of sense to me. And then the patient, said, I never thought just trying to practice an attitude of acceptance would help me feel better. And it's surprising how much better I feel just trying to be more in acceptance despite how shitty things are. I looked at him and I said, well, I guess now, all things considered, you don't see what I mean. All right. See you all later. Have a good Saturday. Have good food. Have good sex. Take good care of yourselves. Take good care of other people in your immediate